โอเคบางอย่างข้อสอบอาจจะเก่าไว้ซะหน่อยแต่เวลายูไปอ่านก็พยายามจะเลือกของใหม่ๆหน่อยแล้วก็เลือกของซึ่งมันชอบถามทริคสมัยรุ่นผมจะทำโน้ตคาร์ดใช่ไหมโลกคีย์เวิร์ดคำตอบที่ common แล้วผมก็เก็บคาเด็กเนี่ยเป็นร้อยเป็นพันเพราะนั้น1 อาทิตย์ก่อนสอบเนี่ยผมจะเอาคาเด็กมา study ผมจะไม่ไปอ่านหนังสืออีกแล้ว once you memorize lock the card deck you don't need to look anymore 1 or 2 days before you take exam eat very well sleep very well take a lot of vitamin so your brain function the old habit right stay up until midnight study the night before exam no good your brain exhausted on the day of exam okay some of you suggest to form a study group. It's a very good idea. Anybody of you, if you come from the same โรงเรียนแพทย์ก็ตั้งกลุ่มด้วยกันแล้วก็ไปศึกษาด้วยกันแล้วก็แบ่ง subject มา study แล้วก็มาเจอสักอาทิตย์ละหนอย่างเงี้ยในหอใช่ไหมแล้วก็มาติวกันทุกอาทิตย์มาลองสอบกันทุกอาทิตย์give them a few minutes they're walking in มีคำถามผมอะไรบ้างบ่าลองถามสิแหมนั่งแต่ยิ้มเฉยซึ่งมัน no good one thing I want to complain to you I speak English punctual ภาษาไทยว่าอะไรตรงเวลามีอย่างได้ไงว่า lecture professor lecture อยู่ก็เดินเหยมา8:30ซึ่งไม่มีความเคารพ professor ครับถ้าผมจะต้องราวเช้านี้ผมจะตื่นตี 4ไปราวให้เสร็จ8 โมงเช้าผมจะมาถ้าอยู่รถจะติดก็ตื่นตี 5นั่งรถมาสิเพื่อ8 โมงเช้าตรงเป้งห้องทุกคนนั่งหมดเห็นไหมนิสัยคนไทยอะไรเงี้ยเหยขึ้นรถเมล์มาพวกผมเนี่ยเตรียมเวลามาตั้ง1 ปีพวกนี้เขามาช่วยมาทำเป็น volunteer ไม่มีการเสียเงิน Why don't we all come and listen every day not in and out Okay next Tom Tenner please
Okay. Good morning. Thank you, Dr. Somkit. Okay, we're going to do pharmacology now. And of course, in 2 hours, can't do all pharmacology, just like all of these. So what I want to do, you're going to get a copy of all these questions. I really just want to hit different areas to remind you of what you remember and what you don't remember. So can I get, oh, I'll do it. Okay, so let's go ahead and oh, that's not too good. Nope. It's okay. I'll just do this one. Good. Thank you. Okay. We'll try that and see if it works. What I've done here, this slide is taken off of the USMLE website, where they talk about the different areas that are covered on the test. As we spoke on Monday, be sure to read the USMLE website page to page, okay, because they tell you exactly what you need to know. And as you can see here, they want you to know general principles. Many of you haven't thought about general principles for a while. Pharmacokinetics, pharmacodynamics, metabolism, pharmacogenetics, toxicities, drug interactions, some regulatory issues. And on this first page, they talk about autocoids, autonomic pharmacology, antimicrobials, and antineoplastics. We're going to just sort of work through many of these with example questions. Okay, general principles. Now, if you are like the students in the States, you hate this part. So I do it first, and then we go. You do it while you're still awake. Okay. Remember Henderson-Hasselbalch equation on acids, weak acids and weak bases. Remember that for a weak acid, the protonated form is non-ionized, and therefore it can move through membranes, lipophilic. For weak bases, the protonated form, which means hydrogen is associated, is ionic, and therefore it is lipophobic, doesn't like lipid. That electrolyte, that charge, acts like an anchor to prevent the drug from going across membranes. So in the stomach with a pH of 2 or less, weak acids will be charged because at low pH, high hydrogen ion, okay, a lot of proton, so it will have a tendency to bind to the drug, and for a weak acid, that makes it neutral. For a weak base, it makes it charged. Weak acids will absorb through the stomach, weak bases will not. Okay, so the first question, an aspirin is a weak organic acid, so that when you see organic acid, you should think proton, no charge. All right. What percentage of a given dose will be in the lipid-soluble form at a pH of 2.5? Now this is interesting because they didn't ask you what percent will be protonated or unprotonated. They asked you what percentage would be lipid-soluble. So you have to remember that a lipid-soluble drug is one that has no charge. For a weak acid, that means it has to have a proton. So what they're really asking you is the percent of protonated weak acid at a pH of 2.5 with a pKa of 3.5. Do any of you remember the Henderson-Hasselbalch equation? Probably not. Just sort of, pass the test, forget it, right? Well, remember one more time. Till you get past step 1, you don't need to remember it as much. Okay. I'm not going to ask you to do the, I'm just going to tell you the answer of this one. Right away, it's 90%. Okay, and let's work through it quickly. Aspirin is an acid, so it will be ionized, more ionized in an alkaline pH because there'll be no proton. Henderson-Hasselbalch, pKa, and again, that's a log. pKa minus pH is equal to the log of the protonated form over the unprotonated form. And you'll get these equations so you can review. But pKa is 3.5, pH is 2.5, subtract those, it is 1. And so 1 equals the log of the protonated to the unprotonated. Again, the antilog of 1 is 10. So you have a ratio of 10 protonated to 1 unprotonated. For a weak acid, protonated is lipid soluble. So the majority, 10 to 1, is lipid soluble in the stomach. But that wasn't the question. They didn't ask you the ratio, they asked you the percentage. So the way that works is you have 10 protonated to 1 unprotonated. What is the percentage? You would do the percentage of the protonated acid over the total, which is protonated acid and unprotonated acid, which is 10 divided by 10 plus 1 divided by 100 gives you about 90%. Okay? 3-year-old was brought to the emergency room after ingesting an overdose of promethazine. You may remember that's a phenothiazine antihistamine. Promethazine is a weak base Weak base, right away, when you think weak base, right? Proton, if it has a proton, it is charged, cannot cross. Unprotonated, lipid soluble. So it's, whoops, oh, all right, well, forget it. Okay, well, we'll work through it anyway. Weak base, pKa of 9, physical exam heart rate is 100 per minute, pressure is 110/60, respiration is 20. So this person has promethazine overdose, and the question is, how do you get rid of it? All right. In the case of promethazine overdose, if you want to get rid of the promethazine, that means you want to excrete it in the urine. So the best way to ensure that it will be excreted is to make it lipid insoluble. You want to trap it in the nephron, kidney tubules, in the urine. So the way to do that then is to protonate, yeah? Because a protonated base carries a positive charge, and a positive charge can't cross back and be reabsorbed. Therefore, you would make it the urine acidic, more proton, more protonated species. And the way you make the urine acidic is give ammonium chloride. This one, bicarbonate, would make the urine basic, less proton, less charged. It would reabsorb back into the body, and you couldn't excrete it, or slower excretion. This is sort of a test-taking also game. If you have two things that are opposite, you may want to study those carefully, because maybe that's where the question and the answer is for the question. And then these are just sort of distractors. And again, same with the answer. I won't waste your time with that. Okay, some pharmacokinetics in terms of drug administration. There are some equations you should remember. The volume of distribution is an important equation. Most of us don't care. I mean, large volume, low volume, you don't really care about it, but it's important because this equation, the volume of distribution, the volume, the apparent volume into which a drug seems to distribute, actually is also the equation for a loading dose. If you ever need to give a loading dose of a drug, you can use this equation. And basically, digoxin, say, has a volume of distribution of 700 liters. Now, even I don't have 700 liters. I'm close, but not quite 700. So it's not a true volume, right? It's an apparent volume. And so drugs that distribute into the periphery and bind, as digoxin does, to skeletal muscle, give you an apparently large distribution into a large volume, okay? And what you have to do in a loading dose is you have to fill that volume up. You have to cover those binding sites to get a therapeutic level. Because remember, when we talk about drugs, the drugs that are effective are free, not bound, right? Okay, so you need to remember volume of distribution. You need to remember the elimination rate and the calculation of the clearance. The clearance in liters of blood per minute is equal to the elimination rate divided by the plasma concentration. Now, another trick for taking exam questions. Sometimes you may totally forget the equation. But if they ask you an answer that is going to be in milligrams per liter, then you can look and see what factors in the equation would give you the right units, and you can work back. So even if you forget the equation, if you know what the units are for the answer, you're in good shape. It's when they give you multiple units that you have to think, okay? All right, and then of course the time half, I like to call this God's favorite number, 0.693. It's everywhere. I don't know why he picked that number. It's a strange number to me, but it works, okay? So the constant, 0.693, times the volume of distribution divided by the clearance gives you the half-life. And again, for us, most drugs are going to be first order kinetics, which means you lose half of the drug in a given amount of time. If a drug has a half-life of 2 hours and you give 1 gram, in 2 hours, half of that is gone, half remains. If you give 1,000,000 grams and the patient lives, then in 2 hours you have 500,000, right? Out, 500,000 remains. So it is independent of the amount of the drug. It's dependent on the ability to eliminate. So it's a constant fraction eliminated per unit time or half-life. Okay, so question. 70 kilogram man, generally they're going to tell you 70 kilogram man. I was actually 70 kilograms at birth. I have grown since then, but I haven't been 70 kilograms since I was 7 or 8 years old, but whatever. That's average normal person. 70 kilogram man, heart disease, requires immediate IV therapy with procainamide from Dr. Wanpen's lecture. Remember procainamide, class 1A antiarrhythmic. Pharmacokinetic values, 70 kilogram person include a volume of distribution 130 liters. Again, there must be some sequestration or binding because, again, I'm not 130 liters, all right? So there's some distribution binding. The clearance is 36 liters per hour, and bioavailability is 83%. Therapeutic concentration is 5 milligrams per liter. And the question they ask is, what is the intravenous loading dose? Again, if you forget, because you have other things to think about, Chinese New Year coming up, other things to do, you don't think, oh, I don't know. But you can see here, milligrams, okay? So you go back up here and say, what combination of these factors might give you milligrams, okay? And the answer would be, let's just 650 milligrams. How come? We'll go to the next one and show loading dose is equal to the plasma concentration times the volume of distribution. And if you were going to give an oral, which is kind of foolish if you're trying to give a loading dose, but if you want to give a loading dose, you have to take into account its bioavailability, which in this case was 83%, but we don't care because this is intravenous. 5 milligrams per liter. We need an answer in milligrams. So if we multiply by 130 liters, according to the volume of distribution equation, we get 650 milligrams, okay? 70-year-old man, same guy. 70 kilograms, sorry, man, heart disease. What constant infusion rate should be used to maintain therapeutic concentration of 5 milligrams per liter? I don't know, do you all calculate these things anymore, or do you have pharmacists do all this for you? I don't know, but it's always good. In case I need something, I would like you to calculate it for me. What constant infusion rate? So now what you want to do is you want to give enough drug that will maintain a therapeutic plasma level. And the beautiful thing about first-order kinetics, what makes pharmacology so special, is that a first-order drug, half is eliminated, one half, 50% is eliminated in a half-life, which means a constant amount, a constant fraction is eliminated. At steady state, to be a true steady state, the amount out must equal the amount in. And so if you want to maintain a steady state level of drug at the steady state, you must replace over time the amount that is eliminated over time. So if you can calculate the elimination rate, then you know the administration rate, okay? And so what would be that answer? 180 milligrams, and why? Because the dose that we give will be equal to the steady state concentration, that concentration that is maintained when the amount of dose in equals the amount of drug eliminated. So you can multiply by the clearance, okay? So 5 milligrams per liter times 36 liters per hour, the amount of blood cleared of procainamide will equal 180 milligrams per hour. Beauty again is that while you want to give 180 milligrams per hour, you know that the rate of elimination will be 180 milligrams per hour, because that by definition is steady state. Same 70-kilogram person, he's very sick. We'll keep playing with him. Calculate the predicted half-life. Again, God's favorite number, 0.693 times the volume of distribution gives you 2.5 hours. Now, actually, today with Hippocrates and iPods, you just look it up, right? You take your Palm Pilot out and you punch in half-life and it just tells you what it is. But you may have to, you cannot use during the test. Okay, so you have to remember this one. Okay, this is where it gets a little more complicated. And I don't know how many of these you will see, because remember, USMLE knows that you only have 1.2 minutes per question. Okay, so you won't get many long questions like this. But in this one, the patient is admitted to the hospital. He has pneumonia due to gram-negative bacteria. They want to give tobramycin with pharmacokinetic data of clearance and volume of distribution of 80 milliliters per minute and 40 liters respectively. What maintenance dose should be administered intravenously every 6 hours, so one shot every 6 hours, to eventually obtain an average steady-state plasma concentration of 4 milligrams per mil. The reason this one is more complicated is because you will know that a maintenance dose means the amount you give every 6 hours now must equal the amount that will be eliminated over 6 hours to get that close to the therapeutic level. And how do we do that? We take the steady state. Remember, rate in equals rate out. The amount in per 6 hours will equal the amount out per 6 hours. And whether you hit the therapeutic dose or not, it doesn't matter. If you give a non-therapeutic dose every 6 hours, you still will set at equilibrium, 4 to 5 half-lives, you will still be putting in as much as you put out. But to get a therapeutic dose, we want 4 milligrams per liter. We multiply that times the clearance. And again, remember units, 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 units. Don't forget units. You will be very smart and know the exact answer. But if you forget the units, it will be the wrong answer. Okay, you got to correct for units. Because remember, this was given as 80 milliliters per minute. The answer was given, you need it in liters because you're going to be working with liters here. So what you need is 0.32 milligrams of tobramycin per minute as constant infusion. Okay, that would be good, but that's not the answer, because they want one IV dose every 6 hours. So how much does that mean? How much do we give over 6 hours? Well, we have to multiply this times 60 minutes, and then that by 6 hours to get the total dose, okay? Remember we said on Monday, make sure you know what the question is asking for. Answer the question, not what you think the question is. Answer the question. Okay, this is pharmacodynamics now. 65-year-old female with edema receives a diuretic of drug X and Y, and they have the same diuretic action. Drug X is given in a dose of 5 milligrams and produces the same diuresis as 500 milligrams of drug Y. What does that mean? Let's just go ahead and do this one. I'm just going to give you the answer. It means that drug X is 100 times more potent than drug Y. Okay, remember, pharmacodynamics is in terms of potency and efficacy. All right, the lower the drug concentration to achieve the same pharmacologic or therapeutic effect, the more potent the drug. In fact, thiazide diuretics are more potent than loop diuretics. However, which diuretics are the more efficacious? Which diuretics make you urinate more? Thiazides or loop? Anybody remember? Loop, okay? So the loop diuretics would be more efficacious, but thiazides may be more potent. Okay, now let's do some CNS again. I took this from the USMLE page: anesthetics, hypnotics, psychopharmacological drugs, anxiolytics, antidepressants, antipsychotics, analgesics, stimulants, anti-Parkinson, all the CNS drugs. Okay, so let's go ahead and we'll play now. Okay, so maybe we'll do the power board on this one. During the morning rounds, you hear a patient admitted the night before with confusion, agitation, and restlessness. All that you know about this patient is she is taking the NMDA, glutamate, receptor antagonist mentamine, or trade name in the US is Namenda. What is the underlying patient problem? Okay, can we start the power board? Can we do it? We'll play. Oh, okay, 10 seconds. We have 149 people. Just guess. Okay, 24 people played. All right. And the answer is Alzheimer's disease. The NMDA receptor antagonists have been approved, I think, just within the last couple of years for the treatment of Alzheimer's. I think the evidence that they are effective is very small. They help a small number of people, but they have been approved by the NMDA, okay? So Alzheimer's was the right answer. Okay. If you don't know, guess. It's okay. Remember, this is very bad. This is very bad. Because you need to get into practice, because on the national board, USMLE, sorry, if you guess right, you get a point. If you don't answer, it's wrong. Okay, so everybody who didn't, the other 120 people all got it wrong, even though you didn't know, so you can guess. All right, let's go to the next one. And let's do this also. A patient who has high abuse potential, in other words, they have abuse for other drugs, complains of feeling restless and on edge. You hear that a lot, okay? Experience difficulty concentrating and sleeping. Your diagnosis is general anxiety disorder, and you prescribe a drug known to be effective, but you want it to have minimal abuse potential. Now, I'm hoping what you're thinking now is that some of these drugs would be good, but they may have higher abuse potential, and therefore they're not going to be a good answer. So let's try power board and see what answers we come up with. Oh, good. Okay. 100 people got this one wrong because they didn't even play, but that's all right. Okay. Whoops. Okay. This is good. Actually, the correct answer is paroxetine. Okay? So 23% got it right. So many put alprazolam and haloperidol. Let's look at the, whoops, sorry. Okay. We'll explain in just a minute. Let's go ahead and do this one. The same patient, all right, after a few weeks complains of jitteriness, insomnia, sexual dysfunction, including aorgasmia. Which of the following would be appropriate alternative drug for the generalized anxiety disorder? Sorry. Buspirone, clomipramine, clozazine, diazepam, and trazodone. Can we do this one? Okay, we can talk about this one. Many different opinions, but this is good. I do this with my students at Texas Tech because this helps me to know, if 5 people know the answer and so 100% get the answer right, then we can't talk about it, right? But this tells me we need to talk about this one. Okay, So let's look at the answer was buspirone, okay? Now, how come? Let's see if we can get some explanation. For the first question, all right, alprazolam is a very good drug for general anxiety disorder, as is diazepam, but again, they have high abuse. So people who have problems with drug dependency are going to want this drug. I have a daughter who is a resident, third-year resident in Chicago, at University of Illinois, Chicago. She's an emergency room physician. She tells me that about 60% of all her patients are not sick. They just want some drugs. Okay, so it's very important that you are sensitive to drug-seeking behavior. Bupropion and trazodone are heterocyclic antidepressants, so they're not really anti-anxiety. Clozapine and haloperidol, and I noticed some people bit on haloperidol. Haloperidol is an antipsychotic drug. Okay, so other side, okay? Actually will calm people down, okay? They're antipsychotics, so they're not used. They're not effective in general anxiety disorder. Clomipramine, tricyclic antidepressant, is good for obsessive compulsive, but not general anxiety. And naltrexone, of course, is an anti-narcotic, opiate drug, which can be used for alcohol withdrawal, but not anxiolytic. Okay. Let's see. 50-year-old female with a history of psychiatric medication presents with stereotypic oral-lingual and masticatory movements, involuntary lip smacking, tongue protrusion. By now, everybody knows this answer. Yeah, okay. So we know what the patient has. The question, though, is what is she most likely suffering from? Abstinence signs due to withdrawal of lithium, neuroleptic malignant syndrome, obsessive compulsive disorder, tardive dyskinesia, and Tourette's. Can we have this one? I'll try to do most of these, I think. I think everybody knows this one. All right. Oh, good. We don't have to talk about this one. Okay? Tardive disorder. Again, tardive dyskinesia. Neuroleptic malignant syndrome is a possibility with antipsychotics, but this is not what was described. So be careful not to jump at the first maybe close or involved or associated answer. Make sure you look for the best answer. Okay, again, tardive dyskinesia. The problem is dopamine receptor blockade for a long period of time. Which one of the following drugs might be used to replace the current therapy? Again, this question refers back to the last. Alleviate the tardive dyskinesia, hopefully, because sometimes it's irreversible, but with minimal risks of other adverse effects. We can do power. Interesting. Okay. Bromocriptine. Okay, that's good thinking, but wrong. No. But again, the problem is, people who put bromocriptine, you're thinking right, because the tardive dyskinesia is due to chronic dopamine receptor blockade. And so your logic is, well, let's put in bromocriptine, which is a dopamine receptor agonist, for competition, which is good pharmacokinetic thinking, bad therapy, okay? Because why is this person taking this drug in the first place? They're psychotic, right? What's that mean? Is their dopamine stimulation up or down? Which way? I got too much. Okay, so and you're giving them bromocriptine, you're just sort of pushing more dopamine receptor on top. This is why I love pharmacology, actually. This is why I'm a pharmacologist, because there's only 3 things that can happen in most pharmacology. Goes up, goes down, doesn't change. I can guess a third. I mean, there's only 3 possibilities. It's simple, right? Even if you don't know, you have a 33% chance of being right. So, okay. Oh, what happened? Sorry, okay. All right, sorry. So what was the answer? So the bromocriptine was good thinking. You were trying to antagonize dopamine receptor blockade. But there's this person is psychotic. So you want is another antipsychotic agent that does not block or does not block dopamine receptors as much. And if you'll remember, the atypical antipsychotic drugs, such as risperidone, are mainly serotonin receptor antagonists and can be exchanged. Thioridazine, haloperidol are wrong because they are dopamine receptor blockers. What's wrong with clozapine? It's dangerous, bad adverse effects, okay, adverse side effects. So agranulocytosis, you don't want to use that one. So risperidone is correct, but people with bromocriptine, this is good. You're not sleeping, you're thinking, that's good. And that's what we said. 5-H2 receptor, dopamine, to a greater extent than dopamine receptor, so it is an atypical antipsychotic. Again, dopamine agonist, but not used here. Dopamine 2 receptor blockade and adverse effects potential is bad. Patient being treated for Parkinson's disease also has benign prosthetic hypertrophy. Which one of the following might be contraindicated? And I know many of you are practicing medicine now. I would suspect that when you see people with Parkinson's disease, usually later in life, that men will also be complicated with benign prosthetic hypertrophy, because if we live long enough, that's what we get. So let's do that one and see what drug. Go ahead. Oh, this one's fun. I like this. Yes, very good. Okay, benztropine. Again, your problem is up here, but if you treat this and you forget this one, your patient will not like you anymore, because this will inhibit the bladder, right? And so they will have urinary anxiety, and that is the answer. Okay? Again, antimuscarinic agent, benztropine, it works in Parkinson's disease in the brain by blocking the muscarinic receptors in that pathway in the cortical striatum. But selagine, levodopa, carbidopa, all are affecting the dopamine and would be good. Ropinirole, again, is a dopamine receptor agonist. Again, these are all good anti-Parkinson's disease agents, but they don't affect necessarily the bladder. Fentanyl transdermal patch has been used postoperatively to provide thermal analgesia. Transdermal analgesia. The most dangerous adverse effect of this mode of administration is cutaneous reaction, diarrhea, hypertension, relaxation of skeletal muscle, respiratory depression. I'm going to let this one go because I think everybody recognizes fentanyl as an opiate, and of course that would be respiratory depression. Okay, that one I think is easy. When the patches first came out, they said you wouldn't get enough absorption to cause respiratory depression, but in fact you do. You can. Again, huge abuse potential with fentanyl. So. Okay, autonomic pharmacology, my personal favorite part of pharmacology. I know everybody hates autonomics, but it's very important. Okay, farm worker. And for those of you who come to Texas to work with us, you will see this a lot. Okay. Farm worker is brought to the emergency department following exposure to organophosphate insecticides from working out in the fields, especially in the cotton fields. They use a lot. He is wheezing, shows signs of severe bronchospasm. Which one of the following would not be a consistent sign of poisoning with an organophosphate? Okay, so you sort of know what's going on. But what would not be an organophosphate? Increased salivation, increased bowel sounds, urinary urgency, mydriasis, skeletal muscle fasciculation, followed by a flaccid paralysis. Can we do power? Okay, 47 of you can come to Texas to work. The others, no. No, I'm teasing. Okay, but that's correct. And, oh, wait a minute, 55% of the 47 can come. No, that's correct, all right? Mydriasis, remember, meiosis, small, mydriasis, large. Now, I don't know much about physiology and anatomy, so how does a pharmacologist remember? Meiosis, small word. Mydriasis, big word, okay? So mydriasis, big dilation, okay? And what causes mydriasis? Sympathetic stimulation. Alpha receptors on radial muscles pull the iris open. What causes meiosis? Acetylcholine, parasympathetic stimulation on circular muscles closes it. So that farm worker who comes into the hospital, when you look at that farm worker, his eyes are going to be very small, pinpoint. My favorite, this is, again, maybe some help. You may have heard this before. My teacher, I don't know, you know what dumbbell is? Dumbbells are things you exercise, but they're also the slow students in the class. So I always remember dumbbell, all right? This is what an anticholinesterase inhibitor will do. Block the cholinesterase, increase acetylcholine levels in the body. A lot of acetylcholine hitting muscarinic receptors will cause D for diarrhea and defecation, muscarinic, urination, meiosis, all right? Bronchospasm, bradycardia, lacrimation and salivation are all muscarinic. The excitation is nicotinic. Remember, acetylcholine levels, the acetylcholine is not being destroyed, and so it's going to hit muscarinic receptors like the parasympathetic nervous system, but it's also going to hit the nicotinic receptors. And again, this one is special, sweating. Remember that sweating is stimulated by acetylcholine, stimulating muscarinic receptors in the sympathetic nervous system. It's not parasympathetic, remember? It's weird, I don't know why, but it's true. Okay, farm workers brought to the emergency department on exposure of organophosphates. We said before he's wheezing, shows signs of bronchospasm. If you don't help him, he will die from respiratory arrest. Which one of the following combination of drugs would be used to treat this farm worker? And can we do this one again on the PowerPoint or power board? This one? I'm sorry, I'm making you work too hard today. Good, okay. Atropine and pralidoxine. Atropine blocks muscarinic receptors. Pralidoxine regenerates the acetylcholinesterase. Now, atropine and epinephrine, again, I think good thinking, because atropine is definitely one of the two. But atropine alone will not help, because atropine will take care of the muscarinic side effects, but not the nicotinic. I know there's a lot of speculation that if you give a very, very high dose of atropine, you would get some nicotinic receptor blockade, but the data is very weak on that. I think only the Army believes it. Okay, next three questions together, all right? 27-year-old woman presents with muscle weakness, including eyelid ptosis, slurred speech, difficulty swallowing. History shows woman is being treated. Gram-negative infection with gentamicin. Following tests have been ordered: thyroid studies, serum creatinine kinase, electromyogram, muscle biopsy. The attending, you all know attending the physician. You have attending physician here. For residents and students, their physician, their mentor, their teacher is the attending physician. The attending physician teases the resident for not ordering edrophonium, which produces a dramatic improvement in the patient's muscle strength when administered intravenously. All the other tests returned normal. Okay, so wasted the money of the patient, basically, because not thinking. The patient's underlying, we won't do this one, this one's regular. Patient underlying condition most likely results from inadequate acetylcholinesterase in the synaptic cleft, autoantibody against nicotinic receptors, impaired synthesis of storage of acetylcholine, impaired release of acetylcholine from terminals, desensitization of acetylcholine. So this is kind of a tough one because you already know it's an acetylcholine problem at the nicotinic receptor, but what they're asking you for is to identify the cause of the disease, and it is autoantibodies, right? This is myasthenia. The aminoglycoside antibiotics create and exacerbate muscle weakness. So what did the gentamicin do? An aminoglycoside antibiotic inhibits presynaptic release of acetylcholine, antagonism of the action of acetylcholinesterase, potentiation of the action of acetylcholinesterase, increasing turnover of receptors, slowing conduction. So think about it. What does an aminoglycoside antibiotic do to acetylcholine and the nicotinic receptors? It inhibits presynaptic release. So if you have a patient with myasthenia gravis and they're getting an aminoglycoside antibiotic, those people are at risk for respiratory arrest because you're hitting them at two different places. The myasthenia knocks out the nicotinic receptors, and the gentamicin inhibits acetylcholine release, so you have two negative effects. Oftentimes, you may not know they're myasthenic until you give them the gentamicin. And then finally, primary treatment of this patient's condition should begin with isoflorophosphate, which is an organophosphate, mefenamic acid, pyridoxine, pyridostigmine, and triorthocresyl phosphate. And that, of course, would be pyridostigmine. Okay, an ophthalmic examination of a 60-year-old man complaining of vision problems reveals increase in intraocular pressure with optic disc changes, visual field defects. This finding strongly suggests primary open-angle glaucoma. Rats, we knew that already. We were going to guess that, not the question, right? Which pharmacotherapy is considered? Pharmacotherapy for the above patient is initially designed, whoops, what happened there? All right, let's jump here. Pharmacotherapy for the above patient is initially designed to open the trabecular meshwork by contracting ciliary muscle. A useful agent for this purpose is. So what we have to think about is what kind of drug is going to pull the trabecular meshwork by contracting the ciliary muscle. That's going to be something that stimulates acetylcholine or a parasympathomimetic effect. So it's going to be pilocarpine. Now I'm hoping that you know that atropine would be bad, okay? You would be in trouble. You give the atropine to this person, everybody would be mad at you. Succinylcholine and tubocurarine are nicotinic receptor blockers, okay? Tubocurarine is a competitive antagonist. It just blocks the nicotinic receptor. Succinylcholine is what is called a depolarizing blocker. It stimulates nicotinic receptors and desensitizes them. But all of that's irrelevant because this is a muscarinic receptor system that we're talking about here. And of course, dexamethasone, not bad, but it doesn't have any effect, would not really be effective on the glaucoma. Injection of a pharmacologically effective amount of an antimuscarinic agent like atropine may, can we use the power board for this one. Increased bronchial glandular secretion, increased heart rate, cause paralysis, constrict the pupil, promote sweating. So what would an antimuscarinic agent do? Okay. Increased heart rate. Okay, the antimuscarinic agent blocks acetylcholine, going to increase those levels. Increased bronchial glandular secretions. In fact, antimuscarinic agent will block. And remember, in COPD, ipratropium is an antimuscarinic agent. It blocks glandular secretions in the bronchi. Paralysis. Paralysis in skeletal muscles is a nicotinic receptor effect. Antimuscarinic receptors have very little action on nicotinic receptors. Constrict the pupil. Remember what causes the pupil to constrict? Acetylcholine on muscarinic receptors. Atropine, actually. In fact, I always tell my students that if they don't like their patient and they want to refract their eye, you can give them atropine. Right? They can't see for a week. They'll be mad and they'll go somewhere else. They'll go to another doctor, right? Oops, okay. And again, promotes sweating. Acetylcholine promotes atropine, raises body temperature. Terbutaline is administered to a woman in her 7th month of pregnancy because of uterine contractions that began during the previous week. Which effect can be anticipated? Will she have increased extracellular potassium, increased gastrointestinal motility, decreased blood glucose and insulin, increased heart rate and possible arrhythmias, constriction of bronchial smooth muscle? Can we do power board, on this one? Quickly. Okay, good. Increased heart rate and possible arrhythmias. Again, terbutaline is a beta 2 receptor agonist, okay? So it will increase heart rate, but not because of stimulating beta 1 receptors in the heart. It will cause arrhythmias potentially, not because of stimulating beta 1 receptors, but because of stimulating beta 2 receptors in skeletal muscle. Blood pressure will drop, right? Diastolic pressure will fall. Who knows? Who gets mad when diastolic pressure drops? The brain. Brain wants more blood. So the brain will stimulate the sympathetic nervous system, which will stimulate the beta-1 receptors in the heart, and that gives actually a reflex tachycardia and potential arrhythmias. Okay. Picture one. The circles represent the size of pupils of a patient's right and left eyes, both without treatment and 2 different treatments. Which one of the following is compatible with the findings shown for the left eye? So basically what they're telling you is that right, left eye, they give no treatment, and what you can see is that the left eye is a little bit myotic. You give treatment with tyramine. Everybody remember what tyramine is? Indirect acting sympathomimetic. Now, mydriasis. Oh, that's good, makes sense. Norepinephrine on alpha receptors, stimulating radial muscle, opens up the iris, but no effect here. Treatment with epinephrine, again, now both eyes are dilated, but this one's even bigger than this one. So the question is, which of the following is compatible with the findings for the left eye? Is it blockade of alpha adrenergic receptors, blockade of beta receptors, blockade of muscarinic receptors, inhibition of cholinesterase, or sympathetic denervation? Can we do this one? Oh, excellent. I like this one. If you know it, I don't have any fun. I can't talk about it. Okay, this is good. What is the answer? It's sympathetic denervation. Okay, how come? Oh, good. Okay. Now, how come? Blockade of the alpha adrenergic receptor, what would it cause? Meiosis? Oh, my bad. Big one. Mydriasis or meiosis? If you block the alpha receptor, you get meiosis, all right? And so that's not consistent with any of these. The pupil did not get smaller. Blockade of beta receptors, that's a distractor. There's no real beta receptors involved in pupillary diameter. Very important for formation of aqueous fluid, but not for pupillary diameter. Blockade of muscarinic receptors. What would muscarinic receptors do? If you stimulate muscarinic receptors, they would do exactly the same thing as blocking the alpha. Remember? There's an antagonism there. If you block the muscarinic, if you block the muscarinic receptors, you get mydriasis, all right? If you stimulate the alpha receptors, you get mydriasis. Inhibition of cholinesterase would increase acetylcholine. In the treatment of glaucoma, you squeeze down, you get small meiosis. So it's sympathetic denervation. And really the trick here is, remember, when you denervate the sympathetic nervous system for some time, you get a super sensitivity. Okay? Let me see if there's another one. Okay, let me go back. Now, let me ask you another question. I think it's important to remember, why did tyramine have no effect while epinephrine had a big effect? Does anybody remember? Tyramine is a sympathomimetic that acts indirectly. If there's denervation, there's no norepinephrine. The tyramine goes in, hits the pre-junctional norepinephrine terminal and causes the release of norepinephrine. In Horner's, that's been cut. There's no norepinephrine. And so this told you that it was denervated, because if the tyramine doesn't work, there's no norepinephrine to be released. On contrast, epinephrine is a direct alpha stimulant. It doesn't care what happened to the neuron. It goes straight into the alpha receptor and causes that mydriasis. Okay, so these two told you that this was a Horner's, a sympathetic denervation. I broke it. Sorry. Thank you. You fixed it. Yeah, that has to be there. Thanks. Okay. I'm old. I don't know how to play with these. Okay, another one. Picture. In the diagram, an unknown drug X is injected intravenously to 6 different animals. So each one of these is a different animal. And blood pressure is recorded. Control animal is untreated. So when this drug X is given, there's an increase in blood pressure, diastolic, systolic. Actually, not much pulse pressure, but diastolic and systolic go up. Each of the other animals is treated as shown. From this data, what are we looking at? Okay, so we got to go up and look at the picture. X in the presence of hexamethonium, no difference. X in the presence of atropine, no difference. X in the presence of reserpine, no effect. X in the presence of imipramine, tricyclic antidepressant, little effect. X in the presence of phenoxybenzamine, no effect. So what's happening here? And we'll do PowerPoint on this one. PowerBoard, sorry. Adrenergic, oh. Oh no, I'm sorry, too quick. That's good. That's my fault. It was too quick. Not enough time to read, sorry. In fact, the answer is activation of alpha adrenergic receptors. Okay, how do we know? Well, hexamethonium, I'll go to this one. Hexamethonium is a ganglionic receptor blocker. Okay, so this drug clearly works distal to the ganglia, sympathetic ganglia. Atropine is a muscarinic receptor blocker, so blocking muscarinic receptors has no effect on this response. Reserpine depletes norepinephrine from nerve terminals. So when you depleted the norepinephrine, whatever this drug is, it didn't work. Okay? Imipramine also blocks norepinephrine reuptake, but it inhibited the ability of drug X to cause a blood pressure change. And phenoxybenzamine is an alpha receptor antagonist. So clearly what happened here is that the alpha receptors were blocked. Okay? That doesn't explain what happened here, does it? Unless you're thinking in the previous question, drug X has to be isoproternol, norepinephrine, epinephrine, amphetamine, or angiotensin II. Can we do this one? Okay. I'm glad that no one put angiotensin II, and this is good. Okay. Sympathetic question, right? The answer is amphetamine. The next question, this is why I like these, because many people picked norepinephrine. I'm glad that not too many people. I wonder how that works. So about 2 people picked this one. But isoproternol is a beta selective sympathomimetic. So it really hits beta receptors, and alpha receptors cause the increase in blood pressure. If you gave isoproternol, again, I love pharmacology. What would happen to blood pressure with isoproternol? Go up? No change, go down. What do you think? Isoproternol, beta selective agonist, down. Stimulates beta 2 receptors in the skeletal muscle. Blood flow runs into the skeletal muscle on the arterial side, and total peripheral resistance drops, and diastolic pressure would drop. Okay? What about epinephrine? Epinephrine is an alpha and beta. So those two kind of balance out. So not too much change. But norepinephrine was a good answer, because norepinephrine is going to see those alpha receptors in the artery, would not recognize a beta 2 receptor if it tripped over it. All right, norepinephrine doesn't see beta 2, only alpha, beta 1. So norepinephrine was a good answer, except if you remember back, and I don't know, can I go backwards without cheating? Well, I won't break it. Let's see, okay. If it was norepinephrine in the presence of a drug, this tells you that this drug did not work if there was no endogenous norepinephrine. If it was norepinephrine, it would have been like epinephrine in the previous. You'd have still seen an increase, because it would directly stimulate the alpha receptors. This drug has to act indirectly. It has to act by releasing norepinephrine to stimulate the alpha receptors. This drug cannot stimulate alpha receptors by itself. It requires the endogenous norepinephrine. And this tells you that it was amphetamine, because if you block the reuptake system, the amphetamine can't get into the nerve terminal to release the norepinephrine. Okay? It is amphetamine. Okay. Another blood pressure. Epinephrine is administered to an animal by itself, A, or in the presence of an antagonist, B. What is the antagonist drug? All right, so what do we got here? When you inject epinephrine here by itself, you see that there is a drop in diastolic pressure, and there's a rise in systolic pressure mediated through an increased pulse pressure, and there seems to be an increase in heart rate. When you give epinephrine in the presence of another drug, it B, now you see the drop in blood pressure, diastolic pressure, I'm sorry. You see a larger increase in heart rate, but now no increase in the pulse pressure or the systolic pressure. So what must this be? Atropine, prazosin, atenolol, labetalol, or reserpine? Can we do this one? Oh, good. All right, very good. This is epinephrine reversal, right? You block the alpha receptors, so you're not going to see, all you're going to see is the beta 2 effect, which drops the diastolic pressure. Okay, good. Okay, cardiovascular pharmacology, again, taken from the USMLE website. Coronary and peripheral vasodilators, antiarrhythmic drugs. I know you don't like them, all right? No medical students like antiarrhythmic drugs, but you have to just learn them for this one, okay? I think my cardiologist friends use beta blockers a lot, but not too much of the others, so, but you have to know them for this test. Antihypertensive drugs, cholesterol drugs, anticoagulants, thrombolytics, and antithrombotics, inotropic agents for heart failure. So, okay. Again, this is an important equation to remember because it will help you with all the cardiovascular questions. If you can remember this equation, then you can control all the questions for cardiovascular. Again, mean arterial blood pressure is equal to cardiac output and total peripheral resistance. Cardiac output reflects the heart. Total peripheral resistance reflects arteries. Cardiac output is comprised of heart rate and stroke volume. Stroke volume is determined by the contractility or the inotropic state of the heart and venous return. Nothing in, nothing out. So you have to maintain preload. Okay? This can be affected. The four main determinants of cardiovascular function are afterload, what sits on the valves before systole, chronotropy, which is the heart rate, inotropy, which is that inotropic state, and then preload, which is the Frank-Starling stretching effect on the heart. So if you remember these, the brain, who cares, really? Really, who cares? Brain cares, kidney cares. These two are not nice people. They want all the blood. They don't care anybody else. They want all the blood to come to them. The brain and the kidney don't like each other. They think the other is stealing all the blood. And when they get mad, the brain that monitors mean arterial pressure uses the sympathetic nervous system to increase afterload, chronotropy, inotropy, preload, make the heart work harder, to put out more cardiac output, to get more blood to the brain. When the kidney, monitoring renal artery, afferent renal artery perfusion, thinks it's not getting enough blood, it gets mad, thinks the brain is stealing all the blood, and it releases the renin-angiotensin-aldosterone system, which increases preload by sodium and water reabsorption through aldosterone, and afterload by squeezing the arteries with angiotensin II. Okay, so we'll look at some antihypertensive agents, the diuretics, renin-angiotensin-aldosterone inhibitors, sympatholytics, and vasodilators. And I'm sorry, why am I telling you all this? Because in hypertension, the brain and the kidney get mad at each other and they start working hard to make the heart work. And that's what makes the blood pressure go up. So what we have to do in fighting hypertension is to knock down the work of the brain and the kidney. And you do that by stimulating fluid, sodium and water loss, by getting rid of, inhibiting the renin-angiotensin-aldosterone system and blocking the sympathetic system. Okay, JS, an African-American male with a blood pressure of 170 over 110 and a heart rate of 86 beats per minute presents in your clinic drug of choice for initial monotherapy would be. And can we do the power board, please? Captopril, propranolol, verapamil, hydrochlorothiazide, or hydralazine? Okay. Very good. Okay, you are all ready to practice hypertensive medicine in the United States because the African American is salt sensitive. They always get diuretic. Older hypertensive patients or Caucasian will get beta receptors or renin-angiotensin or calcium channel blockers because their hypertension is a little different. But according to the JNC7, everybody in the United States, especially African American hypertensive patients, get a thiazide diuretic. 62-year-old female is referred to pulmonary medicine specialist by her family physician because of chronic dry cough. It's unresponsive to medication. She's been taking captopril for hypertension for 3 years. What is responsible for the cough? So they just told us about the cough, and that's and I guarantee you, you will see a cough question with an ACE inhibitor on all 3 step exams, but it'll be hidden. So they're asking what's responsible for the cough, and let me just tell you, it's going to be bradykinin, because the angiotensin converting enzyme that makes angiotensin II also destroys bradykinin, and the cough and the very rare angioedema are both caused by bradykinin. An elderly woman is placed on antihypertensive therapy and quickly begins experiencing orthostatic hypotension. Which one of the following medications could you prescribe to minimize this adverse effect? So this elderly lady is on a hypertensive medication that's making her orthostatic. Which one of the followings could you give her that would minimize that? So we have hydrochlorothiazide, captopril, clonidine, reserpine, and nifedipine, and they're asking you which one of these drugs would cause the least orthostatic hypotension. So let's do the power board. Okay. This one is correct, nifedipine. So how come? All right, a lot of you liked captopril, and a lot of you liked hydrochlorothiazide. Now, I think reserpine, clonidine, and hydrochlorothiazide are, we'll say, really wrong, okay? But why? In fact, she is elderly, and that is the clue here. Most elderly people are volume depleted, okay, especially at this age. They're at least 20% volume depleted. So if you deplete their volume more, then they're going to pass out. So hydrochlorothiazide is a clear bad guy here. Reserpine, clear bad guy, because reserpine, you lose the ability to constrict the veins, right? So that when they stand up, there's no squeeze, grandma falls down. Clonidine, less so, but still the same. It's a decrease of sympathetic tone and reflexes. Now what about captopril? Captopril is praised for being less orthostatic. What's the problem here? Well, remember, captopril is going to block the formation of angiotensin II. The kidney is watching renal artery blood perfusion. It's not getting what it wants. So it sends out renin. Renin clips angiotensin into angiotensin I. Angiotensin I is converted into angiotensin II, goes to the adrenal cortex and releases aldosterone, which goes straight to the kidney and stimulates sodium and water reabsorption. All right, sodium comes in, 8 molecules of water follow each molecule of sodium, So you put volume back into the system. This elderly woman is volume depleted, okay? So if you block her angiotensin converting enzyme, you block the ability to make angiotensin II, synthesize and release aldosterone, reabsorb sodium and water, and therefore her volume depletion becomes even greater than it was originally. Again, for me, plenty of volume, probably not a problem, okay? On ACE inhibitor, I probably would not be orthostatic. But grandma, 83 years old, she doesn't have a lot of volume, and a lot of times she'll become orthostatic. The only drug that will not cause orthostatic in grandma is nifedipine, because it is a calcium channel blocker. And calcium channel blockers are primarily arterial, so not much effect on the veins, not much vein dilation, and so least likely of all of these to cause orthostatic hypotension. 40-year-old Caucasian male with asthma, newly diagnosed for essential hypertension, has been placed on a fairly high dose of an antihypertensive medication. While taking this drug, his heart rate becomes 56 beats per minute. Anytime you see a low heart rate, you should think of a special type of drug. He complains of tightness in the chest and difficulty breathing, another clue. He later claims to be depressed more than usual and difficulty having sex. Of particular interest is that he is particularly sensitive to orthostatic hypotension. That's different. But has no sensitivity to cold. What drug is this patient taking? Prazosin, nadolol, pindolol, atenolol, labetalol. Can we do PowerBoard? This is exciting, waiting. Uh-oh. Okay. Now, okay, what happened? Many people like prazosin. Good thinking, all right? Alpha receptor blockers cause orthostatic hypotension, okay, a lot. And so that was good. But an alpha blocker could not explain this low heart rate, because when you block the alpha receptors, total peripheral resistance falls, venous return to the heart falls, blood pressure falls. Who knows? Brain's not happy. Sends out sympathetic tone. Doesn't matter. It's not going to affect the veins. It's not going to affect the arteries. But what happens in the heart? Stimulates beta-1 receptors, and heart rate has to go up. So prazosin cannot be the answer. It does cause orthostatic hypotension. Where is it? But it does not cause bradycardia. The other answer everybody liked was atenolol. And again, atenolol is, you will notice atenolol was named after me. Tenorman? No? No, it wasn't. But I tell everybody it was, but it wasn't. No. Okay. Atenolol is a good answer because atenolol is a beta-1 cardioselective beta blocker, and it will cause a decrease in heart rate by blocking beta-1 receptors. And it can even cause some difficulty breathing and bronchospasm, even though it's not supposed to, right? Beta-1, cardioselective. But again, all the beta blockers, even cardioselective, if the dose is high enough, can cause some trouble breathing. But atenolol will not cause orthostatic hypotension. Okay? What you have here is the orthostatic hypotension is caused by an alpha blocker. The bradycardia, difficulty breathing, depression, and difficulty with sex are caused by a beta blocker. So what we have here is a drug that is both an alpha blocker and a beta blocker, and that's labetalol, okay? 3 beta blockade to 1 alpha blockade, all right? And how do I know? I know because somebody stuck a little A in there. You see, all the other beta blockers are LOLO, LOLOL, all right? So I can remember what they are. Labetalol has an A there. And that tells me that labetalol blocks both beta receptors and alpha receptors. Using the above vignette, our guy who's having trouble, which monotherapy would be appropriate for this patient? Okay, he's got trouble. He's falling down when he stands up because he's got orthostatic hypotension, he's got bradycardia, he's depressed, and he's not doing well with sex, okay? And remember, hypertensive guys, they don't hurt. They feel okay. And then you say, oh, you take this pill, good for you. And then they can't have sex, they don't take it anymore, they just don't come back. They say goodbye, all right? And then their high blood pressure goes up, and in 10, 20 years, they have end organ damage. So you have to take that into consideration. So what drug might we give our patient that would be better for him than maybe labetalol? Oh, it's there. Okay, that's not a right answer. We won't do this one. Enalapril. Okay, why? This is going to continue to give him low heart rate, depression, bronchospasm, and inability to have sex. Prazosin is going to give him orthostatic hypotension. Hydralazine is a direct vasodilator. It was interesting. Hydralazine works by stimulating potassium channels and hyperpolarizing the arteries. But it is a third string drug, never given alone, because when you drop total peripheral resistance, the brain and the kidney start pumping out sympathetic tone and renin-angiotensin, so it's not a good antihypertensive agent unless you have all the other drugs there. So hydralazine is never used as monotherapy. Again, we already know labetalol is the wrong answer, so it is enalapril. Enalapril will lower total peripheral resistance, will decrease blood volume, will not cause problems with sex, orthostatic hypotension in young guy. Okay, so enalapril would be the best for monotherapy for this patient. Okay, let's look real quickly at lipid-lowering drugs. You use a lot. These drugs are widely used in the U.S. I think almost all the cardiologists that I know in the United States are on a statin right now, whether they need it or not. I'm not sure why that is. But we have several main categories of drugs. The statins are the HMG-CoA reductase inhibitors are probably the best, most effective, widely studied, evidence-based support in improving survival. They inhibit cholesterol synthesis. There are drugs that work out in the gut, cholestyramine, and a new one now called ezetimibe, which unfortunately had some difficulty with some clinical trials lately. Didn't do as good as they thought it would. But these work by preventing the cholesterol from being absorbed. Niacin blocks the packaging of VLDL and decreases triglycerides, as does gemfibrozil, a fibrate, inhibits triglycerides. So gemfibrozil, or the fibrates, and niacin are better at decreasing triglycerides and increasing HDL, good cholesterol. Statins, cholestyramine, and ezetimibe are better at treating hypercholesterolemia, less effect on triglycerides and good cholesterol. 45-year-old male takes simvastatin for hypercholesterolemia. However, his cholesterol remains above the target at maximal doses. Cholestyramine is added to the therapeutic regimen. What drug interaction can occur? And I'll just give you this one. Cholesterol can inhibit the GI absorption. So oftentimes these two drugs will be used together, but you have to have them take one at least 2 to 4 hours before the cholestyramine, before the statin, because the statin will bind to the cholestyramine. Both drugs go in here and come out the other side. They don't do anything, okay? So not effective. The other thing is that the statins, just for point of reference, it says here his cholesterol, they put him on a statin, and his cholesterols remain above the target even at maximal doses. Statins have a very flat dose response curve. So when you give them, if you don't get the response you want, you may as well stop and get a different statin, because giving more will not give you much better cholesterol lowering potential. That makes sense? It's interesting, you can go from one statin to another. One may not work, the other will work, but they have a very flat dose response curve, so that if you don't get your effect within maybe 2 doublings of the dose, you should get another drug. Mechanism of action of organic nitrates, nitroglycerin, in the treatment of angina is, I'll just give this one to you as well, increase intracellular cyclic GMP. Now, I apologize for this question. It's not a very important question, but it reminds me that the step 1, at least, is still going to be very much on mechanisms. As physicians, you don't care. You could care less. Cyclic GMP, you don't care. Okay, you just want to know, is it going to drop cardiac work so that their pain goes away? But for the step 1, you have to remember mechanisms. I'm sorry, it's just, they're going to ask you this. All right, for failure, the way we play, oh, this isn't very good color, sorry. Okay, this is my way of remembering heart failure, the drugs that are important. This is supposed to be red. Oh, it's red there, but it's not red there. Red hearts are healthy hearts, yeah? Blue hearts, not so healthy. What's the matter with yellow hearts? When you see a yellow heart, what does that mean? Indeed, dead. Patient's dead. Yellow hearts are bad. Okay. So if you look at all these drugs that have been used for heart failure, ACE inhibitors, the aldosterone receptor antagonist spironolactone, and a new drug called eplerenone, aldosterone receptor antagonist, the beta blockers, and a combination of an afterload reducer, hydralazine, and a preload reducer, isosorbate dinitrate, have all been shown in clinical studies to improve survival in heart failure. Not by much, okay? 5-year survival for heart failure is 50%. These drugs can improve survival to 65 to 75%, okay, at 5 years. So it's good, but it's not great. Cardiac glycosides, digoxin. Do you all use digoxin or digitoxin? Which one do you all use? Europe uses digitoxin. The States use digoxin. You use digoxin? Digoxin? Okay. Digoxin has been used for 200 years for heart failure. No improvement of survival. Symptomatic relief is excellent, okay? If they're coughing and congested and, distended, and you want to give some inotropic support, good. But they do not make them live longer. The reason for that is that, let me just say, diuretics also improve symptoms but not survival, as do some beta agonists in the acute, dobutamine, say, in acute decompensation. Improve symptoms but not survival. I think the reason for that is that half of all the people who die in heart failure die from what? Half the deaths. Ventricular fibrillation, right? They go into VFib and die. So not much improvement, but symptomatic is very good. And the alpha agonists, calcium channel blockers, and milrinone used to be used a lot, but more people die than live. So it's worse. Survival is worse with these drugs, so they're not used. The phosphodiesterase inhibitors, milrinone and amrinone, are used acutely in a hospital situation for a decompensated patient to sort of get them back, and then you stop and put them on other drugs. But basically, chronic therapy is an ACE inhibitor, a beta blocker, perhaps an aldosterone receptor antagonist. These improve survival, and then these are added to give support. All right? Okay. Hypothetical series of pressure loops, left ventricle control subject and the patient before and after digitalis. Based on these data, which one of the following groupings is correct? I apologize, this may not be seen, but this is left ventricular volume, and this is left ventricular pressure. So these are volume pressure loops, basically, and I'll just tell you, this one is control, this one, Z, is in failure, and then DIG shifts this curve to the left, okay, to improve function. Vasodilator of choice in patients with congestive heart failure is, can we do this one on the, it's nitroprusside, captopril, furosemide, hydralazine, or nifedipine. So based on what we've just discussed, which one do you think we're using? Okay, it's kind of all over the lot, but this is the correct answer. Now, I put this one up there because it makes me mad as a pharmacologist, because captopril is not a vasodilator, right? It's an angiotensin converting enzyme inhibitor. It causes vasodilation by blocking angio-2 formation, but to me, hydralazine is a vasodilator, nitroglycerin is a vasodilator, but captopril is called a vasodilator, so you may as well think of it as such. Just for this one question, rest of the time, no. Okay. But anyway, captopril is the correct answer because it is a vasodilator. Furosemide has very little effect on vascular tone. Hydralazine, nifedipine, of course, is just wrong. Should not use calcium channel blockers in people with heart failure. Nitroprusside is a good answer for acute failure, but you can only give it intravenously in a short period of time, so it's really not going to be very good for long term. Hydralazine, no data that it improves survival alone. Okay, sorry, antidysrhythmics. Actually, Dr. Wampen, I think, showed you this already. Class 1, sodium channel blockers. Class 2, beta blockers. Class 3, potassium channel blockers. Class 4, calcium. And Class 5 are miscellaneous. I like to think of Class 5 as vagomimetic, because in this class are adenosine and digoxin, and they act. Digoxin actually acts through the parasympathetic nervous system and acetylcholine as an anti-arrhythmic, and adenosine mimics acetylcholine. So, question on antiarrhythmics. All of the following are effective at protecting the ventricle from rapid rates, but generally fail to convert atrial fibrillation, with the exception of, which otherwise stated is, which one of the following actually converts atrial fibrillation? Can we do power on this one? The choices are verapamil, esmolol, adenosine, dig, and ibutylide. Okay, let's start it and see what you think. Okay, only 29 people are applying. That tells me it's almost time for lunch. I think everybody else has gone to sleep, but that's all right. What did we answer? Digoxin. Okay, you like this one. Now, have you all heard of rate and rhythm? That argument for atrial fibrillation, control of rate and rhythm. Actually, the answer is ibutylide. There is no real difference apparently, from the evidence-based standpoint, when you try to control rate, you're saying that you don't care what the atrial rate is or if the heart is synchronized and in rhythm. You only want to protect the ventricular rate. And you would do that by interfering at the AV node and slowing conduction through the AV node. Drugs that would be effective at controlling rate, are verapamil, the beta blocker, IV beta blocker, esmolol, adenosine, and DIG. All of these drugs, calcium channel blocker, beta blocker, acetylcholine mimetic, if you will, slows conduction, and DIG, which is a parasympathomimetic drug, all will slow or impede the ability of those atrial rhythms from getting into the ventricle, so you can have whatever rhythm in the atria, but a slower, more effective rhythm in the ventricles. Only a butylide would actually be effective at converting rhythm. In other words, breaking the atrial arrhythmia and allowing sinus rhythm to take over the heart, bringing it back into normal rhythm. Data now are about 60% effective. Okay, so you can give it intravenously, and about 60% of the time you can get back to rhythm. Unfortunately, within a very short period of time, depending on age and the size of the atria, they go back. But the argument is rate. Do you control the number of impulses that go into the ventricles and thereby allow for an effective ventricular contraction, not worrying about the rate? Or do you want to control rhythm, where you have the atria and the ventricles beating in synchrony? Okay. A butylide is a class 3 potassium channel blocker, similar to amiodarone, and these others, of course, we already discussed. Okay. Okay. I don't know that they can take 10 more minutes. They may fall right out of their chairs. Several people, I see. Oh, no. Okay. All right, let's do it. Patient with history of chronic obstructive pulmonary disease presents with supraventricular tachycardia that is limiting cardiac output and inducing heart failure. Which one of the following treatments could be used to not predispose to bronchospasm? And this is a favorite for step one. They're going to throw a bunch of contradictory or contraindications at you and make you kind of pick and choose between a number of drugs that actually could all be used. You know, if I asked you, what could you treat supraventricular tachycardia with? You could probably tell me, well, I hope you wouldn't use this one, but you could probably tell me all of those, all right? But the question is limited by the fact that this patient has chronic obstructive pulmonary disease. That's going to eliminate any drug that might worsen the ability to get air into the lungs. Anything that might bronchoconstrict is not going to be wanted. And so that's going to eliminate pretty quickly things like esmolol, okay, propranolol. Also, what else? You do not want to limit their cardiac output or induce heart failure. So you don't want to have a strong negative inotropic effect, which might affect verapamil. So what answer did we pick? Verapamil. Okay, what did I do? I screwed that up. How did I do that? Oh, their problem is their heart failure is not due to cardiac insufficiency. Their heart failure is due to too rapid a rate. In other words, the heart's being driven so quickly that you can't get preload to come in and fill up the heart. So in this case, verapamil is not going to be contraindicated because the problem is not cardiac contractility. The problem is rate. But the nice thing about verapamil is that it would also give you some bronchodilating effect and not worsen their COPD, where the others would. Okay. Again, off the USMLE website, you can look at those. The drugs to remember are going to be antithrombotics, anticoagulants, and thrombolytics. such as streptokinase and TPA. 65-year-old grandmother has developed atrial fibrillation which cannot be converted to normal sinus rhythm. For prophylactic stroke prevention, the most appropriate oral therapy would be, okay, so you need to give her an anticoagulant. Can we have the power board on this one? Warfarin, heparin, aspirin, abciximab, and streptokinase, okay? Okay, warfarin, aspirin. Okay, now, warfarin is the correct answer, but a lot of people put aspirin. Aspirin's a good answer for younger patients. You know, if you have a 35-year-old, you don't necessarily want them on warfarin for the next 40 years. That would be, you might want to try aspirin. But, in fact, for atrial fibrillation, warfarin is the drug of choice. Aspirin is oral, but it's a wrong answer here because, again, of her age, okay? You want to put her on warfarin. The older the patient, old age, female, atrial size, when those all three add together, the incidence of thromboembolic stroke goes up very quickly. And so you want to put them, in fact, what you would do probably is put her on heparin first to prevent further formation of the clot, and then get her on warfarin, and then in 3-4 days you could cut back the heparin. But the question asked for oral therapy, and of course heparin can't be given orally. And again, that's kind of tricky, but those are the things you need to be watching for when you read these questions. 58-year-old smoker prevents with ECG changes, diagnostic of myocardial infarction. Patient undergoes percutaneous coronary angioplasty with placement of a stent and receives integralin. I don't know who named these 2B3A inhibitors, but I would like to beat them up because I can't pronounce any of them. What they ensured is that I use the trade name so the drug companies can make money. You know, abciximab, I'd much rather say Riopro, but anyway. All right, integralin. This anti-clotting, oh, I just gave away the answer. Oh, sorry. Okay, I will give you the answer. You get inhibition of the 2B3A. Now, I don't know you all are familiar with that, but the way the platelets look like little cookies, okay? Little almond cookies floating through the blood. And when they activate, they start sending out legs, pseudopodia, and they grab on one to the other and they form that amorphous plug. The way they form that plug is by sticking out a protein combination called glycoprotein 2B3A. And that glycoprotein binds to fibrinogen. And so the 2B3A on this platelet grab onto fibrinogen at one point, the 2B3A of another platelet grab onto fibrinogen at another point, and they cause that platelet plug. If you can block the 2B3A, which is never exposed, in the resting almond cookie formation, no 2B3A. 2B3A is inside. It's sort of like a jet. You know, when a jet comes in, the plane comes into land, it puts out its landing gear, right? In a resting platelet, 2B3A is hidden. In an activated platelet, the 2B3A comes out and grabs onto fibrinogen, and that's what links all those platelets together. If you can block the 2B3A, you block the platelet aggregation. Okay, I'll go ahead and stop here, okay? Now, there are still many more questions on the CD that you'll get, and the right answer is indicated, okay? So you can use those to study.
Some question and answer, please. Volunteer, please ask. Did I create? good impression เชิญเลยครับยกมือถามมาสักคนสองคน too heavy duty หนักเกินไปหรือเปล่า This is the way how the basic science people thinking using basic science to apply clinical science. You have to understand in-depth mechanism to apply to the clinical side. Any comment, Tom?
Exactly. As we were saying before, these questions are not that difficult. They're more to alert you to what you need to study. But the questions, they're not going to ask you perhaps a straight question, such as this one. Now, this one, you had to know a tibiphatide, and you need to know it's used for stents. But what they're going to do is they're going to build a scenario that's going to give you some pathology, pathophysiology perhaps, and then the pharmacology. And they're going to wrap diagnosis and therapy sort of together, so that you aren't going to necessarily have a pure physiology question. For instance, warfarin. I told you the other day you will see warfarin on the test. They will wrap warfarin into an atrial fibrillation question, and the beautiful one is they'll say, Grandma Moses come in with atrial fibrillation. Are you going to shock her? Give her a butylide, or they might say a class 3 antiarrhythmic. Going to give her heparin, going to give her warfarin. Well, I got one more, aspirin. All right? So you need to know, you're going to be thinking, oh, this is a diagnostic question. Do we want an antiarrhythmic? You're going to have to think about which one you want to give, and you have to go for that best answer.
Okay, this first day we have a lot of med students on the back. ขอถามหน่อย
Welcome.
ใครอยากจะเป็น pharmacologist ข้างหลังมีใครบ้างยกมือหน่อยสิครับ Nobody want to be a pharmacologist? I mean basic science teacher in pharmacology. I'm sorry, wrong.
It's so simple. Up, down, no change.
มีใครอยากจะเป็น anatomist สอน anatomy มั้งมีเปล่าไม่มีเลยโอเคอยากพวกคุณใครมีอยากจะเป็นหมอยุรกรรมมายกมือมาหน่อยไม่ยกมือนี่หมายความว่าไงข้างหลังฮะข้างหลังนักเรียนแพทย์ที่มาใหม่ๆไม่มีเลย too much shy no response I don't want to say anything okay who's second year ปี2ยกมือหน่อยสิปี3ปี4มีซีเนียร์ไหม third year fourth year senior so all of you third year ปี3 how many of you plan to take USMLE step 1 very soon this year or next year ยกมือหน่อย nobody no interest Okay, we see you after lunch.
Well, thank you. Before we go into lunch, I have several announcements, and